collect the consent of the patient. And the HIE similarly execute agreements around, sort of being willing to return data in a circumstance where we've had an identity-proofed patient coming from a personal health application. So we have been setting this up, and we're just so grateful that Rochester RHIO was the HIE that was really in with us on this from the very start, when we just tried to do this for a handful of patients manually without actually setting up the gateway. Like, could we actually facilitate the delivery of HIE quality data to a patient coming directly from an HIE, but with the app as the middle person and then the middleman in the middle. Again, we vet the apps. Information blocking rules allow for patients to choose the app that they want, but there's a certain amount of vetting that we do to make sure that they really are a patient-facing app and that they are properly doing identity proofing and collecting consent. We also have an option for what we call walk-up patients. So patients who really are not interested in long-term having an application, but who want to get their data from an HIE, they come on to the Citizen platform temporarily to be identity proofed, and then their data is it's available to them for a 7-day period for them to download, and then at the end of 7 days, the information that sits on Citizen platform is destroyed. So it doesn't get retained. The patient needs data another time, they have to go through the process again, but that doesn't require them to make a long-term commitment to any application in order to get their data. And so that's the way that proceeds. So I'm going to turn this over to Sarah so she can talk a bit about like why the heck she signed up for this and what's the value proposition for them. So go ahead, Sarah.
Great, thank you, Devin. So I'm going to tell you a little bit about Rochester RHIO and a little bit about our history as an HIE. I'm going to touch on how the Cures Gateway fits into our broader equity strategy as an organization, and how we are how we are going to be rolling this out within our community, and then some of the challenges that HIEs have in providing data. Some of them are solved by Cures Gateway, and some of them are ongoing points of discussion and discovery. So I'm with Rochester RHIO. We are a community-driven health information exchange located in the Finger Lakes region of New York State. We are one of the 6 qualified entities of New York that make up the SHINE, the Statewide Health Information Network of New York. And like all HIEs, our goal is to share health information in a secure environment to improve care and to reduce system inefficiencies. Traditionally, we think of system inefficiencies with an interoperability lens, making sure that providers have the right information at the right time, reducing duplicative testing. But with the requirement to provide data to patients, I think we're starting to think about system inefficiencies from a patient lens as well. Patients have a tremendous administrative burden in trying to gather their records, especially patients with complex chronic conditions, patients trying to get qualified for clinical trials. There's a big, patients getting second opinions. There's a big administrative burden in gathering all of those records from many different care providers. And so we have an opportunity as a health information exchange to reduce inefficiencies for patients and make it easier to get their information in one place. Next slide. So some key stats about Rochester RHIO. We have more than 1,000 facilities, practices, hospitals that contribute data to Rochester RHIO. That includes 23 regional hospitals and nearly 300 community-based organizations. There's some statistics there about the transactions for our core services that we offer as a health information exchange. We have over 300,000 unique logins to our clinical query portal and over 500,000 patient record returns or searches for patients in our portal. We sent over 450,000 alert notifications, lots of direct message transactions flowing through our HISP. We deliver over 23 million unique lab result messages into EHRs, and we received over 105 million unique clinical transactions in 2021. I think the key that's really important when thinking about giving patients access to their data is the depth and breadth of data in our health information exchange. We have really diverse data providers, from labs and radiology providers to community-based organizations that provide some kind of clinical information. And as we start to think about social determinants of health, particularly for Medicaid populations, getting more information on social determinants of health information is really valuable across the community and valuable for patients as well. Next slide. So shifting to a lens of diversity, equity, and inclusion, in Rochester, New York, like in many communities during the pandemic, Rochester was confronted with racial tension. Specifically in the summer of 2020, in our community, there was a Black man who was killed during an encounter with police. And that kicked off a wave of protests and deep, painful community conversation about racial inequality in our community. And as a result of that incident and the community discussion, the Greater Rochester Black Agenda Group declared that racism is a public health crisis and asked individuals and organizations to sign on to that declaration. So we joined over 170 organizations and over 3,000 individuals in our community, and we signed on. And it's not a matter of just signing your name and saying, yeah, we agree, racism is a public health crisis. You have to actually do something to affect change in your community. So we thought about how we as a health information exchange can be impactful in improving health equity and reducing systemic racism in the spaces and places where we operate. And that is in how we operate as an organization. So building diversity in our governance, building diversity in our workforce, providing additional training on DEI for our organization, thinking about the language that we use as technologists and being careful about not using terms like, whitelisting or blacklisting, and being intentional about the way we describe our technology. We have a project called the Health Data Equity Project, where we're working with our sources on improving the quality and completeness of race and ethnicity and gender data in the health information exchange. And we're also focusing on opportunities that address systemic change. And for us, the Cures Gateway is an opportunity to work with organizations that are serving patients who are dealing with the impact of systemic racism and are at the receiving end of health inequity. In us helping those organizations give patients access to their data, then patients will have information that they need to empower themselves to receive better care. Next slide, Devin. And so with the Cures Gateway, our commitment to health equity is really rooted in community collaboration. We were one of the early pilots with Citizen for the Cures Gateway, and we quickly saw how this was really applicable to many patient populations, not just Black breast cancer patients. So we're piloting the implementation with our healthcare fellowship group, which represent community leaders of 70 different healthcare organizations, community-based organizations in our region. We are piloting with them and specifically collaborating with a few federally qualified health centers that serve diverse populations. One is an FQHC that serves an urban Black and Hispanic population. Another is an FQHC that serves LGBTQA population. And then we have another one that serves a rural migrant farm worker community. And we'll be working with them to train their staff and to understand how the process works or doesn't work. And then thinking about how we might improve the workflow, work with citizen to address any challenges or hiccups. I think I'm aware, and we're all aware as technologists, that systems are created for default users, and patients who most need access to their data are the patients with the lower health literacy, with perhaps challenges in having access to computer systems to actually request their information. And so in piloting with these community-based organizations and these stakeholders who serve specific communities, we'll be able to learn from their experience and improve after we roll things out. And then next slide. This slide has just a few challenges that really any HIE might encounter in providing access, patient access to data in compliance with the info blocking rule. So one is identity proofing. As a health information exchange, we've got lots of process and policy and systems around provider access to our system, but we do not have a patient-facing department or system. Identity proofing is expensive, and so we're able to leverage Citizens' platform and Citizens' method for identity proofing. Another challenge is that there can be inconsistency in data from different data sources. The HIE can have duplicative data from multiple data sources. I think it's a learning opportunity on the data quality side as we start to provide information to patients. And I think it's also a matter of working with organizations who will be assisting patients in getting access to their data to understand places where data is duplicative or confusing. I think it's also important to overcome the perception that we're completely replacing a provider's patient portal. And then the second point, concern on timing of data availability to the patient. Those are the two big, I think, pushbacks or concerns raised in our community by our health systems. Why would a patient ever need to go to the HIE when all of their data is within this health system? Well, patients go elsewhere. Patients receive services from across the healthcare ecosystem, and health systems can't control that. Payers can't control that. And so I think it's a matter of messaging to the health systems. This is a solution. This is not the only solution. Not all patients are going to need this, but some patients will, and it's our responsibility and legal obligation to provide patient access to their data. And then in terms of concern on timing of data availability, there are some carve-out exceptions to the info blocking rule around certain kinds of tests and having them have some timers on when they're released to patients. We are working with our data providers to ensure that the rules that they have in place in their own patient portals on release of information is included in the messages that we get, and that we have logic to also follow those timing rules in how we release data. In terms of how it's sustained, we are an early adopter, so we have an advantageous contract with Citizen, but certainly as we continue to think about patient access, it is in the future something that we'll have to think about in terms of our budget and in terms of how we pay for it within our funding stream. And then lastly, improving health literacy in communities most impacted by health equity challenges. I think our role is to provide access to the data, and our role is also to empower providers to help patients understand their information. It's not our role to be in between the relationship with between a patient and a provider. And so strengthening our community collaboration and our community stakeholder relationships, I think is really key.
I think that's it
That's
for the
that's
slides.
it.
Yep.
Yeah.
Yep. I'll turn the stop share off. And
Such a powerful story, and so great to know that this work is happening. It's really terrific. And there's lots of questions in the chat. Do you want me to go through them, or Devin, it looks like you're.
yeah, it was hard to the minute I started to try to pay attention to the chat to look at questions was when I accidentally advanced Sarah's slides a little too fast. So I stopped doing that. So there's a question for you, Sarah, on whether Rochester RHIO maintains a clinical data repository, or are you a model that just pings the requests to the data sources and then pushes the data back?
We do. In New York State, there's some regulations around providing data to the Health Information Exchange. We started building our clinical data repository in 2007. Not all of that data is currently available because we've migrated platforms, but we do maintain, everything from 2014 on is available in our clinical data repository, and then radiology reporting from all eternity is available as well.
Yeah. Some other questions include, like, if it's free to patients, and Sarah mentioned that as an early adopter, it's free to her as an HIE. So how the heck is this getting paid for? And then to Sarah's sustainability question. So, in terms of the citizen platform, we are free to patients, and we will always be free to patients. What helps support the free provision of the PHR is when a patient does agree that they will contribute their data for research, that data is licensed to companies that are interested in receiving it for research purposes. And then a portion of those license fees is provided to the patient and to an advocacy organization if the advocacy organization is helped us to recruit that patient. But that helps to pay for the platform, and enough patients say yes to sharing their data that we're able to basically support the services for individuals who are, who for whatever reason, they don't want to share their data, and that's okay. We want to be able to support them in their ability to access data. And then in terms of supporting the gateway going forward, we've calculated sort of the biggest cost that we face, I think, is a little bit of, some ongoing maintenance and maintaining security and approving apps going forward and just running it. Once it's all set up, that those costs will not be terribly significant, but the ID proofing costs, turn out to be between, $1 to $5 a patient. Most of it is done through vendor contracts. They follow very similar processes around, requiring a presentation of a government issued photo ID. There's another question about this in the chat about how the ID proofing gets done. And then a check with the DMVs in states that allow their databases to be checked for authenticity of those documents. And then usually there's a biometric aspect of it to bind the person to the document. So, somebody didn't just pick up a driver's license that they noticed on the floor and start registering for someone's medical records. And then a kind of an authentication, out of band authentication step around, the return of a code that gets sent to your phone or to your email. We're all sort of familiar with how we all do that for remote transactions today. So that's generally how it's done. And the expectation is on the apps to perform this service. And then Citizen picks up those patients who are the walk-ins or walk-ups that don't want to come with an app, but just need to be identity proofed. And I could see, down the road, we might even offer an opportunity for patients to basically pick an identity provider, right? Just as long as you can there's a credential that can be presented for your ability to get records, we might be able to run it that way too. It's not the way we're initially setting it up, but it could be that way in the future. And then, in terms of HIE charters and sort of, who's who can do that, you know, whether HIEs might not under their current charters be able to do this. And I want to give a shout out to a number of other HIEs that are some HIEs that are in the audience today. I see Dan chimed in. You know, the folks from New York, Rochester leaned in with us very early, but we have some other early adopters, including one in California at Santa Cruz. We're super excited to have them on board. So
if I could add on the identity proofing. So this is actually not Rochester RHIO's first go around with patient access to information. We did a pilot back in 2012 with Microsoft Health, which is like since been wound down. And, you know, we had a lot of challenges. We used Equifax at the time to identity proof patients, and patients didn't like having to give their credit information. Patients needed an email address, and we had couples using the same email address, but they both wanted access. And so it was painful. And I mean, that was 10 years ago. So to have an organization who's going to do the identity proofing solution for us, much better. And
agree.
There's also a question about inconsistency of data from different sources. So we have had patients who discover either errors or perceived errors in their information. We have most of our patient requests to date have been around consent and who's accessed their information, but occasionally a patient will see something in their patient portal, but contact us to get it corrected. I think it's important to note that not everything that a patient perceives to be an error is actually an error. And as the health information exchange, we need to be good stewards of the data, but it's not our data to change. So we always, in those circumstances, point the patient back to the data source, and then we use our relationship with the data source to validate with them, is this data that needs to be removed and corrected? But we are never the ones who are making that determination, because it's the data source's responsibility to address that at the source.
Yeah.
I have a quick question on the CBOs piece. Really, it's amazing. You have 300 CBOs that are also part of the HIE. Do they have access? Are you providing them access to?
They do. In some cases, if it's something that makes sense. So we have the ability to segment information in our system. Some CBOs only need demographic information. They don't need the entire clinical. So some CBOs might have a limited access. Other CBOs actually are HIPAA compliant, and we go through as part of our assessment in onboarding participants whether they are a HIPAA compliant organization in their process and policy, and how they, you know, their HR policies and whatnot. And if they are, and they have a need to see clinical information, then we do provide access to our systems. And some of them are CBOs that also do care management. So it's the care management records that we're receiving in many, many cases. Some of them are, you know, working with health homes, or CBOs that are providing substance abuse treatment or things like that. That tends to be the kind of information that we receive in those cases. Some of them are simply providing enrollment information so that you know that the patient is receiving services, with the hope that in the future we might be able to consume social determinants of health information from them, for example.
Well, I'm sure we could spend our entire hour on this. And I am looking, I think the questions are getting answered here in the chat. So I just welcome you to continue to put questions in, and Devin and Sarah, if you could also just stay for a few moments and see if you could answer in chat. And what's so fantastic is to know that you both are here as resources too, because as California continues to build the network of networks, it's going to be really important to kind of reach out, and, you know, you've already gone through a lot of this and have solved it. So that's fantastic. And Jim, I see you're raising your hand.
I do, and I don't want to be difficult. I know I've had the pleasure to talk to Devin.
Trying to move
directly about
on.
it a
That's
couple
okay.
But yeah, I'd still like to understand the ID proofing thing, because I know you mentioned the fact that Equifax didn't really work, and TransUnion or LexisNexis. I mean, I guess just that construct. Are you leveraging CBO provided information? Are you striving for an IL level 2 verification? And for me, kind of why it sticks in my craw is that, and Marilee is on here as well, this has gotten into a bit of a food fight within care quality and the advisory board as to how much identity proofing you do, and most importantly, how much that participating healthcare organizations and the HIOs, HIEs are willing to accept that identity as part of exchanging data. So thanks very much.
Yeah. Yeah, no, we are striving for IAL2, but that's because we want a standard. And IAL2 is put at those standards are established by NIST, which are established for the federal government in terms of ID proofing, but they're the only ones we really have to point to. And unfortunately, at IAL2, it leaves some populations out, right? People who don't have government issued photo identifications. If there is a knowledge-based authentication component to it, people who haven't had sufficient transactions in the economy to have generated, sufficient data for those questions to be asked. You can't overly rely on knowledge-based authentication for IAL2. You'd still need, government issued IDs to be presented. Only 35 of 50 states, 50 plus states participate in the database that will validate from the DMV perspective. So, but yet identity proofing one is like nothing. Identity proofing one is like saying, okay, like I'm authenticating through my Gmail account or through my Facebook account, which is not, you can't really rely on that if you're going to be sending medical records to somebody. So there needs to be something, frankly, that works a little bit better. That's a little more in the middle, that allows us to make sure we're serving all the populations who should be getting their data this way. And whether that's ever going to be sufficient for some data holders, I don't know, but that's where, frankly, it would help for some of the federal authorities to provide some clarification on what the expectations are, so that people don't feel like they're taking on too much liability when they accept something less than absolute certainty. Yeah.
Sounds like a great fact sheet, Robbie.
Indeed.
Hi,
Yeah,
Devin.
I mean, we've had in our internal discussions the fact that we know we're going to leave it. What we're trying to now actually collect data through research and anything you can contribute to be able to say, if we choose IA level 2 as a bar, who gets left behind, what percentage of people, what percentage out there. Jennifer Blumenthal herself from one record said, I tried doing IA level 2 and had problems with it. So,
Yeah, it's not easy.
Robbie, this is Courtney Baldridge from US Aging, and I apologize. I've just jumped into this call from another one. Being on the social care side, and our agencies receive funding from Older Americans Act, as well as contracts with integrated care providers, MCOs, and others. We have a range of HIPAA as well as PI. Certainly in the social care space, where we are receiving consent. I know one of Jim's favorite things in the world. We're working on consent and receive it on our side. I'm just curious and interested to understand what the expectation for engagement is there, and your hope in terms of being able to connect with, through, and to the social care entities that have some pretty specific requirements and obligations given their funding sources to patient match and verify these folks.
Yeah, so I mean, Sarah, I don't know if you want to speak to how you handle the sort of connection of community-based organizations to RHIO as an HIE, because the easy part of facilitating patient access in the way that we're doing this is, well, at least it seems easy to me, is that the CBO doesn't have to handle all the sort of obstacles. Once they're connected into Sarah, she's already connected into the gateway. That data can just come through in a query for records when the patient has asked for it. But you know, to the extent that there are barriers that social organizations face in providing data to patients in the first place that might be legal, then just creating a mechanism to make that easier might not be enough. But I don't know what you think about that, Sarah.
Yeah, so So on one hand, there's the patient consent-based access to information in RHIE. So CBO, even a non-HIPAA covered entity CBO, if they sign our participation agreement, they are allowed to access patient information in Explore Plus, our clinical query portal, and receive alert notifications with affirmative patient consent in accordance with New York State policy. In terms of contributing information, we do require a security compliance assessment when we connect with any technical system, any EHR. So if the CBO is using a system that is not self-hosted in the cloud with a larger vendor, then we have an easier time than if they're using a small homegrown system. That being said, if they're not able to pass a security compliance assessment, there may be a way that they can, for example, format data into a CSV flat file and drop it once a day or once a week into an SFTP folder that we can ingest, turn into, messages that we can ingest. As the HIE, it would be great to say that everyone's using the most technical standards like, FHIR, but when you're dealing with healthcare entities and other entities that are across the spectrum, not everyone is going to be technically as capable. And so we need to work with everyone where they are and hopefully move them along the continuum. I think in our community, part of the conversation might be with our 1115 Medicaid waiver, perhaps, can there be some dollars to provide technical assistance to CBOs to connect so that they can provide this valuable information? Perhaps that's some of the conversation that we need to have in our state as an example. But I think it requires creative ways of getting that information. I think then providing the patients access to their information is, a couple steps away. You have to ingest the data, make sure that it's of value, of quality, that it means what you think it means. It's useful for the community of healthcare providers, and you can provide access to patients. I also see a question from Dan. Rochester RHIO currently has consent at the HIPAA covered entity level, opt-in, opt-in or opt-out to access data. In New York State, you can also say no at the HIE level. We call it the hell no. But New York State is moving to an all-in consent model where the patient would opt in. The patient would not have the ability to block access to their data in this new model, but would be able to have their data be unknown and therefore accessed only in an emergency. That process is long, and there's a technical design and build happening right now to sort of get that information from all of the QEs into a centralized place. And there's also some policy changes and implementation things that are happening in the state. So it's been, a years long process, but something that we are moving toward here.
Fantastic. Well, again, thank you so much, Sarah and Devin, and continuing to do this great work, and exciting to know that you'll also be bringing it to California through Dan and Santa Cruz. So Dan, you're on the hook to continue to provide us updates. I will just hopefully, if you don't mind sharing your contact information, Sarah and Devin, I'm sure many folks here would really find the contact with you valuable and follow up. So I encourage to have conversations outside of today as well. Thank you again. And I'm going to hand it back over to Robbie as he will take us through the latest, greatest from the meetings that just occurred this week at the state.
Yeah, really quick summary. So just in case you missed them, CalHHS has had 2 webinars since we last met. So one is an informational one. They'll be having a host of these, as well as the Implementation Advisory Committee, which is kind of the the next version of that larger stakeholder advisory group we were tracking earlier this year. And just to highlight some of what they went over at that implementation advisory committee meeting. First, you can see on here, here's a list of the policies and procedures that they'll be going over over the next few months to have in place next year. I would just say one of them, information blocking. So they do plan to extend information blocking provisions to entities that may not currently be covered. So that was one of the questions that came up, as well as defining real-time data exchange. And I think we'll see what CalHHS I think proposes in the coming meetings on that. Qualification process for HIOs. I don't think we heard anything too new here, but really just trying to create a qualification process for HIEs to be able to be those data intermediaries. Budget, I would highlight this for folks. A couple key areas here where stakeholders may be able to receive budget dollars that were appropriated for implementation around education grants, technical assistance, and HIO onboarding too. And you can see under potential recipients who these dollars might be able to go to. Lastly, just around digital identities and provider registry and consent, I think there's a really great summary provided as to what was in that final strategy document. And I think we'll see more to come. And then just lastly, there's a great DHCS summary of all the various data sharing or initiatives that have data sharing components. You can see them here. I think we've done a pretty good job at covering most of these in our meetings in terms of where Medi-Cal's at.
This was really great to see because we've been asking for connecting the dots. And so it's good to see that dots are getting connected.
Yeah.
Jim, I see you have a question.
Oh, yes, thank you. Real quick, I'm just curious on the previous list for the identity strategy. So is the concept of a statewide person index really going to be a thing? Or is it still just, is it just kind of still up there? Have you heard any, and I don't know if there's anybody from CalHHS or something on the call to be able to answer that, but if RHIM was here or not, but.
I think RHIM is on the call.
Okay.
RHIM, do you want to join in on that? Are you still here?
Yeah, I am still here. I don't have a whole lot that I can say on that other than we did talk a little bit at the IAC meeting yesterday about that we're taking very seriously exploration of a statewide person index. And so that will be a continuing discussion as we move forward in the coming months. I think that there will probably be much more concentration on that topic at the next IAC meeting. So I'd invite people to call in then.
Excellent. Thanks, Rim. Appreciate it.
Bill sits on the committee, so I don't know if you.
I'm not on the IAC, but I'm on the HPD advisory committee, and I know HPD is working on the digital identity strategy as well.
Awesome. Okay. I'm back to you. Sorry, we're really
No, I'll
figuring
just,
this out.
I'll just we have one slide here with just a summary of some of the feedback that was provided. I think, as we learn more and more details about these different pieces of the DSA puzzle, I think we'll have more to report out. But I think it was a great level setting meeting. I don't know if maybe anyone has maybe one or two quick comments they'd like to share before we move on. All right. List of upcoming meetings. You can also find these on the CalHHS website as well. And I think with that, we wanted to have a follow-up discussion around compliance with the data sharing agreement mandate. And we've got Bill Barcelona in the room in real time. I think, Bill, we're curious maybe from your association's perspective for providers, or what are you hearing in terms of knowledge about the DSA and maybe any issues or questions that are coming up for your members?
There isn't a broad understanding of the implementation of the DSA among providers at the present time. I think this subcommittee on the PNPs is going to help dramatically. Where we're focused at APG, we focus on provider groups. What is really, I think, attractive about where the agency is going now with yesterday's meeting and then Friday's meeting on the PNP subcommittee is that there's a strategy around that to develop the certification and standards for HIOs.
Mhm.
And I think that's huge. I mean, most, when you're talking about Medi-Cal, it's delivered through small providers, even though they're organized into large groups. At the end of the day, the people who are actually delivering the care are small providers.
Yeah.
They're going to need access, for example, to ADT information. I mean, that's the number one job, I think, for this information exchange goal that we've got in DXF is we've got to get small providers linked into the hospitals so that they know when their patients are hitting the ERs, being admitted, and facing discharge. And then we can do a much better job. That is the low-hanging fruit of care coordination. And that, to me, is job number one of data exchange. The other thing, the other drum that I will bang, that I always do, is provider registry.
Mhm.
And having clear sense of where the providers are, who they're contracted with,
Who the PCP is.
what their names are, what their specialties are, and
Mhm.
having accurate information. And so building in an accurate provider registry into this data exchange process is, to me, it's fundamental.
Awesome. Yeah,
Okay.
I think I know one of those issues came up yesterday just around a PMP around transaction patterns. What sort of data do you need to send when you get any given request from another signatory? So it sounds like that will be tackled. And the directory question came up too around, can we get a director of who do we send the data to, when we get a request?
Yeah.
So that came up too.
Yeah.
And I think we're just hoping to capture here, some of the input we received last time, from a CPCA as well as a healthcare attorney, all the way from, we need a signature line on the data sharing agreement, all the way to, how will we be, concerns around, serious concerns about things like treatment of reproductive health data, and is there need for additional policy, just given kind of the legal landscape right now. I see there's a question from Rita. Are the provider registry the same thing as a provider directory?
Yes and no. And we don't have time for me to go into this because this is my life, but provider registry needs to be a living, not a document, but it needs to be a living system. It needs to be informed from all the different contributors about an individual provider's identity, such as a health plan, an IPA, the individual provider themselves. It needs to link to all of the contractual relationships that individual provider has with all these different payers, so that we can navigate through the system and figure out, eliminate the duplication of provider identities. For example, get those 200 pesky physicians who practice in Albuquerque, New Mexico, out of the covered California provider directory. Those sorts of things.
Great example.
Yeah.
And we do have so I guess I'm going to ask a fairly naive question, but the IHA provider directory that we were working on together a few years ago, is that still in the mix?
It's still there. It's still in progress. APG's also working with the original vendor, Gain Healthcare, to renew provider organization participation in a single portal. And when we started that several years ago, it was called Sanator. We're reviving that as well. That can link into Symphony. It can link into the state.
Symphony, thank you.
The job is to make sure that the provider groups are complying with SB 137 requirements in California.
Well, thank you, and keep us posted with what you're hearing, and we'll continue to contribute to that. Thank you.
Excellent. Well, I know we've got about a minute left.
We did pretty well.
I think just to note, we'll keep having this discussion at our meeting. So we'd love, if you'd like to raise your hand and let us know what your organization's thinking. We'd love to, keep adding to the list here in terms of input and feedback. just a reminder, meetings through the year, our next one's October 6th. Make sure, if you register if you haven't already, if you got a link from a colleague. And just a couple other updates and news items we wanted to share. Next week, Manifest Medics will be hosting their Evolution California event in San Francisco. We've got a couple news items in here, including our very own Timmy Leslie was featured on the HIMSS cast, talking about California's data exchange efforts. So check that out. As well as a couple other events. Aligning for Health is having a really great event next week around social determinants of health with a data sharing component to that conversation. Care Equality's annual meeting is on December 13th. It sounds like there may be a lively discussion around identity proofing, Jim. And then lastly, just to note for folks, CDPH does have a Test to Treat equity grant out there available for safety net providers in California for purposes including health IT. So, thinking about the health IT data sharing connection to connecting people with COVID therapeutics like Paxlovid and such. So please check that out if your organization may be eligible or you might be able to partner with another.
I can put it in the chat and the deadline is September 30th. So it's coming up.
Excellent. And I think that's all we had for you all today.
Well, thank you everyone for joining us. And it's great to be able to be a little bit in person. We'll figure out these hybrid meetings soon and we'll see you soon. We'll see you in 2 weeks. Thank you.
Thanks, everyone.
Thanks, everybody.